Welcome to Medicare for All Explained. This podcast will enlighten our listeners and dispel the distortions that surround Medicare for All. Medicare for All Explained is produced in collaboration with Physicians for a National Health Program and is hosted and produced by Joe Sparks. I'm your host, Joe Sparks. This is episode 66, our Insidious and Nefarious Healthcare System. My guest, Scott Goldberg, is an assistant professor in general internal medicine at Albert Einstein College of Medicine and an attending primary care physician at Montefiore Medical Center in the Bronx, where he sees patients and teaches residents in the primary care and social internal medicine program. Dr. Goldberg has worked closely with Physicians for a National Health Program since starting medical school. He started a student chapter at the University of Chicago Pritzker School of Medicine and became a student delegate to PNHP's Board of Directors from 2013 to 2016. From 2016 to 2019, he was a member of PNHP's Executive Committee and Board of Directors. He was reelected to the board in 2021. Dr. Scott Goldberg, welcome to Medicare for All Explained.
Yeah, thank you for having me, Joe. I appreciate it.
You have an interesting story. At least I think you do. What got you interested in single payer?
Yeah, so I knew very little about health insurance, healthcare, single payer until 2009 when I was actually at a conference, a student conference for an organization called Physicians for Human Rights, and heard a talk by David Himmelstein, one of the co-founders of Physicians for National Health Program, about single payer. And hearing that talk just sort of flipped a switch in my mind about the sort of critical need for national health insurance in this country. I graduated from college in 2005 and worked in public radio afterwards for a few years, and didn't actually decide to go to medical school until 3 years after graduating, and but had come at this decision to go to medicine from the perspective of someone who's interested in social justice and equity, and but more from a global health perspective. And so I just was a few months before I was to start this pre-medical post-bac program, I attended this conference in Rhode Island and heard this talk by David Himmelstein, and just thought that there was no sort of bigger and more critical issue that I saw within healthcare than single payer. There would be no, I think, reform that would so drastically impact so many, citizens of this country, and felt like something that I really wanted to commit my life's work to helping make a reality.
So once you got into premed and started seeing what was going on, did it reinforce the need for single payer?
Yeah, you know what? I mean, I didn't see as much in pre-med as I would later see in medical school in terms of the need for single payer. I mean, I knew when I saw David Himmelstein's speech in 2009, I knew that once I got to medical school that I would start a student chapter of Physicians for a National Health Program, which I later went on to do. I mean, I think that's something I saw in my pre-medical, extracurricular experiences. One of the volunteer experiences I took part in when I was doing my pre-medical studies was working with this study that was a large cohort study of people living in Baltimore who were living with HIV and injected drugs. And, although it wasn't the thrust of the study wasn't looking at their healthcare access or, just in talking to some of the study participants, it was clear that, having sort of unequal access to care played a big role in their lives and in their health and their ability to be healthy. A lot of people had presented to care later than they would have if they had if they had guaranteed health care access. And that this was before the expansion of the Affordable Care Act or the expansion of Medicaid. So these were a lot of people, particularly a lot of single men who had no health care whatsoever or no health insurance whatsoever, unaffordable for them to get it. So, and that was something that I saw early on, but it wasn't until medical school and obviously into residency that the need for a single payer became even more apparent.
And even when you were in medical school, you joined PNHP Students for a National Health Program.
Yeah, so I went to University of Chicago, and one of the first things I did when I got there was find some other students who were interested in national health insurance, and we all got together and formed a student chapter, and we found a great faculty member who became our advisor, whose name is Phil Verhoev, who's a longtime member of PNHP and is also on the board of directors of PNHP. So he was our faculty advisor. And, that first year we did a lot of, I think, really great things just in terms of educating our student body, in terms of working with other groups in the community on issues that they were working on. Because I think one of the biggest things that I think we probably haven't done a good job of within the Medicare for All movement is working with other progressive organizations for whom their primary issue isn't single payer, but for whom a single payer system would greatly improve and make their struggles easier to fight. So I formed the chapter in 2012 and then became really involved in trying to expand student chapters nationwide. So I feel honored to have worked with a lot of the sort of early student leaders within PNHP around that time in 2012, 2013. People like Richard Bruno, who's one of the first students to really be involved with the organization. Danielle Alexander was another person. These people that were a few years ahead of me at other medical schools, but I really looked up to them in terms of their early involvement with the organization. And then we really worked to expand student chapters nationwide. I think now there are something like 70 chapters, student chapters of PNHP, and at that time I think there were maybe 10 at most, back when we started ours. And we started having an annual student meeting, which was something new. Towards the end of my time there, we helped organize a national Medicare for All Day of Action across campuses across the country, which has continued, I believe. So, and then I was asked to be on the board of directors as one of the student delegates in 2013. So I was on the board from 2013 to 2016.
And now that you've been a doctor for several years, what concerns you most about people getting medical care?
Yeah, our healthcare system is so dysfunctional that it almost feels like I can't go even one encounter without seeing how a single payer system would make that encounter better for myself and better for my patient. It's just, the system is so insidious and nefarious and just generally accepted at this point. But I feel when you peel back, you just step back just a little bit, you can see how everything about the system is so inhumane for patients and for providers. So, I work in the South Bronx, which is an area that is where people are living in pretty extreme poverty for the United States. And, it's interesting because on the one hand, most of my patients have access to insurance. They have Medicaid. Most people are eligible for Medicaid, so they'll have Medicaid or Medicare. There are some patients we take care of who are uninsured, but those tend to be recent immigrants to the country, particularly from West Africa. But for most patients, they do have access to insurance. So the problem for my patients it's not uninsurance, it's really underinsurance. Or the insurance they have, it's so limited in terms of what they can get, particularly around, just like networks of providers, who they can see, what medicines they have access to. So I think that's, for me, is the main issue. Is like, I mean, as a provider, like, patients have, even if they have Medicaid, right? Because Medicaid now is pretty much mostly privatized. They have different managed Medicaid plans. So in New York City, my patients may have Health First or Fidelis or other managed Medicaid plans, and all those managed Medicaid plans have different formularies. So, like, I may prescribe a medication to one person that I think is right for them, but it's not actually on their formulary, whereas it may be on the formulary for another managed Medicaid plan. So that's like just one instance where I think is a big issue for my patients, which is like, what medications are on formulary, which ones can they get, pretty much usually if they're on Medicaid for free or with very low cost, but it may not be the best one for them. So, I mean, the list goes on. I could talk about that just forever, but yeah.
Well, first of all, I'm going to make what I hope is a humorous comment. Well, it's a shame we can't mix and match formularies like we do for the COVID vaccines now.
Totally. Or like, I've worked at the Veterans Administration in residency. I rotated at the VA hospital, and the VA hospital was like an amazing place to practice medicine. Like, there was one formulary for everything. You knew what was available. You didn't have to guess. You didn't have to like, now I put in an order for a medicine, and then I sort of just cross my fingers that it's going to be approved and hope that the pharmacy doesn't call me back and say, oh yeah, this medication isn't on formulary, or this medication is denied. You need to do a prior authorization. At the VA, it's a universal formula. You know what's on there. At the VA, you know that your patients are going to be able to get into the specialist that you need to see. Like, that you can contact the specialist. It's just, we have a socialized medicine system in this country. Not even single payer. We have socialized medicine. We have like a National Health Service at the VA, and it works. And we know that the VA has lower costs, it has better outcomes, and generally higher patient satisfaction than people who have to navigate, the healthcare system outside the VA.
Well, you bring up, I think, two important points. One, in spite of some highly publicized problems, the VA actually provides very good care, perhaps some of the best care anywhere in the world. And I think that's often overlooked in discussing the VA. Do you agree with that?
Yeah, totally. I mean, studies consistently show that the VA has the best outcomes when it comes to things like, management of myocardial infarction, management of other chronic diseases. Yeah, I think some of the problems with the VA are publicized because it's a public system, so it actually is transparent. Whereas, like, how can we criticize a private system? There's nothing transparent about it. But, studies do show that the VA does outperform, certainly for-profit institutions and even not-for-profit institutions on, important quality metrics. And at a lower cost, for the overall system at large. I think just, I generally don't give much stock to attacks on the VA because policymakers, people want to privatize the VA. So these attacks are ways to sort of weaken the VA and make it susceptible to being privatized in certain ways.
Well, one thing I never understood is why we insist on privatizing our system even more when the evidence is clear that for-profit privatized systems, well, I think they have failed. Our system is broken. We have the most expensive health care and get some of the worst results of any industrialized nation. So I don't expect you to have an answer, but why do we keep pushing to make a broken system more broken?
Yeah, I mean, the way that I see it is, healthcare is one of the few, like, there are certain sort of public services, healthcare, fire department, police department, public education. Healthcare is one of the few public services that is as privatized as it is. And we see it in education. in the sort of charter school movement and the way that people have been trying to privatize public education for, decades now. And so we see that in healthcare. And so for me, like the increasing privatization of healthcare is just an opportunity to take more money from, the public and funnel it up towards the people that run healthcare, the people who sit in CEO offices in the private insurance industry, in the pharmaceutical industry, and the politicians that they lobby and donate, extraordinary amounts of money to influence how the system is allocated. Like if the public had its say tomorrow, we would have a Medicare for all system. We've seen that in polls, and we saw that most recently in all that, exit polls in the presidential primaries, which was that, or presidential elections, which is like a majority of people favor a Medicare for all system. But the reason we don't have that is because the elected officials who make these decisions are, basically backed by some of the most lucrative and well-resourced lobbies in the history of the world. And so it just feels like ever more like there's just trying to take out even more, privatize even smaller and smaller sections of what is left of public insurance, which is, basically Medicare, Medicaid, and the VA. And I'm not sure if you've talked about this in your podcast or we'll be talking about it, but, we're seeing this now with what are called the direct contracting entities, which would be a way to take even more older adults out of traditional Medicare and place them into the hands of Medicare Advantage plans, which is basically private insurance industries getting paid to administer what should just be a public good.
And giving people no choice in the matter.
Exactly, and giving people zero choice, exactly.
I want to come back to something that I think doesn't get emphasized enough, and I said I had 2 points. And one is that having health insurance doesn't mean that you can get access to the health care you need. And you mentioned that with underinsurance. And I just want to say that point I don't think gets emphasized enough.
Yeah, I mean, they often say, I don't know who says it, or maybe I just heard it this last weekend at the PNHP annual meeting, but everyone thinks they have good health insurance until they actually have to use it. And, I think that's the truth is like people are happy with the insurance they have until they have to use it. Once they have to use it, they realize that, there are significant copays and out-of-pocket expenses and deductibles they have to meet. And so, I think the Affordable Care Act really pushed or accelerated the rise of these high deductible plans where it's basically just like health insurance in name only, because no one could actually, with these plans, because particularly, they have low premiums because people who will buy them on the exchanges are generally in that sort of income range where they're not poor enough to qualify for Medicaid, but they're not really wealthy, or but they're not wealthy enough to actually afford what health insurance costs. And so then there's kind of in that middle range where, they can only really pay whatever, a few $100 a month for some really terrible health insurance plan, but the deductibles are so high. So it's just like, it's basically protecting them against, catastrophic care or some catastrophic injury, but it doesn't actually give them access to things that they need, like preventative care or medicines or, subspecialty care if they need it. It's basically to cover them against, protect them against bankruptcy. And even then, sometimes it doesn't even do that. We still see, that medical bankruptcies are the leading cause of bankruptcies in the U.S. And that's despite, I don't know the exact number, so I don't want to, don't quote me on it, but I think something like maybe a half or more of people who have medical bankruptcies actually have health insurance. And that's insane. That's insane.
I certainly agree that it is insane. So based on what you've said, and I think it gives you a good lead-in, how would Medicare for all help?
Yeah, I think the one thing I would say about Medicare for all, I think the language that we use is important. I think Medicare for all now is kind of it's like it's generally like an accepted phrase. I don't think single payer was something that most people understood, even though it's self-explanatory. Like it doesn't have a great ring to it. So that Medicare for all has been taken up as like the new slogan. Better than Medicare for all. Like I think we should be saying improved and expanded Medicare for all. I mean, it's not as catchy, let's say, as Medicare for all, but that's really what we're asking for because, if you expanded Medicare to everyone tomorrow, it would still have a lot of inadequacies, not covering dental, vision, or long-term care. Medicare's actuarial value now is about 60%. So that's why people get supplemental care to take care of the other, say, 40% of their care that Medicare doesn't cover. So Medicare for all isn't sufficient, but an improved and expanded Medicare for all would be sufficient. If we really look at like the package of benefits that the Canada's Medicare plan provides, I think that's really what we're looking at. Canada's Medicare actuarial value is about 80% of care. So I think that, that's I think we should be talking about Medicare for all. Because I think if you ask some of my patients who have Medicare alone, they have a lot of gripes with the system. It's the patients who have Medicare plus Medicaid who are sort of best taken care of. But it's those folks who have Medicare but aren't poor enough to qualify for Medicaid that they really fall into this gap of like not having enough money to pay for their co-pays, pay for their medications. And I think when we talk about Medicare for all, it's important to say that we want, a public Medicare for all, that we're not talking about Medicare Advantage plans. Medicare Advantage is just another way of basically allowing corporations to make profits off of a public good. And we know that Medicare Advantage, it has, I think over the last 10 years, has been responsible for basically $300 billion of money that could have gone towards, like in the form of subsidizing and paying for, private insurance companies to deliver Medicare. It's responsible for about $300 billion that could have been spent on actually like improving traditional Medicare. So I just think like when we're, Medicare for all, I think is a good slogan, but I think it's important to be clear about like that we would want, obviously, in a true national health insurance system to remove Medicare Advantage and to improve the package of benefits that Medicare provides. But yeah, I mean, we can talk about the ways in which Medicare for all would improve the system. I mean, I always think it's important to say that we are simply talking about just a change in the financing of the system. It wouldn't necessarily correct a lot of the disparities that we see among different race and ethnic groups. It wouldn't necessarily, by just necessity improve the healthcare delivery system, but it certainly, I think, would allow, or it would make it easier to reform some of the problems that we see in other aspects of the healthcare delivery system. But I don't mean to diminish what it would mean to get Medicare for all, because we're talking about Medicare for all. We're talking about basically eliminating one of the most profitable industries in the history of, in the history of the world, of the insurance industry. We're talking about a multi-trillion-dollar industry, and obviously that they won't not put up a fight to prevent that from happening.
Well, a couple of points. One, on social media, I've heard people say, well, Medicare isn't that great because it also has, co-pays. And I don't think Medicare has many deductibles, but it does have co-pays, and there are expenses, and it doesn't cover vision and dental. So I think it's important to make the point that you did, that the expanded and improved Medicare for all. And one of the things in terms of racial inequities, it would be hard to change attitudes, but one place where Medicare for all would help is it could get resources into medical deserts in urban areas. In a lot of rural areas, as I'm sure you know, have lost hospitals. We could get some hospitals back in those areas. And I think that's important to realize.
Mm-hmm. For sure. I agree with that.
Scott, I want to thank you so much for being on Medicare for All Explained.
Yeah, thank you so much, Joe. It's really a pleasure to be on your show, and always happy to talk about why we need Medicare for all. I hope to see it in my lifetime.
As do I. I probably have less of my lifetime left than you. I think you're a lot younger than I am. So.
Well, we got to make it happen in your lifetime, then.
Well, thank you.
All right, take care.
You have been listening to Medicare for All Explained. Remember to tell your family, friends, and colleagues about this podcast. Information about Medicare for All Explained can be found at our website, medicareforallexplained.org. The music for this show is Super Bubbly by Jesse Spillane. The logo was created by Lily Sparks. Thank you for listening.